Now, welcome to Chapter 18, the Cardiovascular System series, beginning with the heart. If I were to ask which organ of the human body intrigues you the most, the majority answers will be the heart. Despite its vital importance, the heart does not work alone. The heart is no more than the transport system pump, and the blood vessels are the delivery routes. The heart is actually two pumps side by side. The right side of the heart receives oxygen-poor blood from body tissues and then pumps this blood to the lungs, where it picks up oxygen and expels carbon dioxide. The blood vessels that carry blood to and from the lungs form the pulmonary circuit. Pulmonary means lung. The left side of the heart receives the oxygenated blood returning from the lungs and pumps this blood throughout the body to supply oxygen and nutrients to the body's tissues. The blood vessels that carry blood to and from all body tissues form the systemic circuit. The heart has two receiving chambers. The receiving chambers are the upper or superior chambers of the heart. The right atrium receives blood returning from the systemic circuit. The left atrium receives blood returning from the pulmonary circuit. The heart also has two main pumping chambers. These are the lower or inferior chambers of the heart. The right ventricle pumps blood in the pulmonary circuit. The left ventricle pumps blood into the systemic circuit. The heart is about the size of a fist. It weighs less than a pound. It is enclosed within the mediastinum region of the thoracic cavity. It extends from the second rib to the fifth intercostal space, from the second rib to the fifth intercostal space. It sits on the superior surface of the diaphragm. It lies anterior to the vertebral column and posterior to the sternum or the breastbone. It lies to the left of the mid-sternal line. It has a base, which is on the posterior surface and is directed toward the right shoulder. It also has an apex, which is inferiorly facing towards the lower left hip. If you press your fingers between the fifth and sixth ribs, just below the left nipple, you can easily feel the apical impulse caused by your beating heart's apex where it touches the chest wall. This is an anterior view of the external anatomy of the heart. This will be our right side. This will be our left side. This is your right atrium, also called the right auricle. Auricle is the flap on the external chamber of the right atrium. This is the auricle of the left atrium. This is your right ventricle. This is your left ventricle. This is the apex that is going to face inferiorly towards the left leg or hip. Here's your superior vena cava, your inferior vena cava. Here's your pulmonary trunk, your left and your right pulmonary arteries. This is your arch of aorta, where it branches off into three main arteries, your brachiocephalic trunk, left common carotid artery, and your left subclavian artery. This is a posterior view of the external anatomy of the heart. This is the base of the heart. You can also see your right and left pulmonary veins that will dump into your left atrium. This is your aorta, the arch of aorta that is going to continue on as your descending aorta. This is the internal anatomy of the heart. Here's the chamber of the right atrium, the right ventricle, the left atrium, the left ventricle. This is your interventricular septum. Inter meaning between. What are we between? The ventricles, right and left ventricles, and septum means to separate. The heart has 3 layers. It has the outermost layer, which is the epicardium. It has the middle layer, which is the myocardium. And it has the innermost layer that is going to line the walls of the ventricles as well as the vessels. It is called the endocardium. The endocardium. We have several valves, 4 to be exact. We have right-sided valves. We have left-sided valves. The 2 atrioventricular valves will include your tricuspid valve and your bicuspid, or also called the mitral valve. Atrioventricular because they separate the atrium from the ventricles. The right atrioventricular valve is the tricuspid valve. The left atrioventricular valve is the bicuspid valve. Our next category of valves will be our semilunar valves. The semilunar valves, we have one for the right side and one for the left side. The right-sided semilunar valve is the pulmonic or pulmonary valve. The left semilunar valve will be your aortic valve, your aortic valve. Your atrioventricular valves are attached to collagen cords called chordae tendineae, the strings that are seen here. They are nicknamed heartstrings. They anchor the cusp of the atrioventricular valves to the papillary muscles seen here. The papillary muscles are protruding from the walls of the ventricle. The walls of the ventricle are also made up of muscle. That muscle is called trabeculae carneae. When the heart is completely relaxed, the AV valve flaps hang limply into the ventricular chambers below. Blood flows through the open atrioventricular valves into the ventricles. When the ventricles contract, compressing the blood in their chambers, the intraventricular pressure will rise, forcing the blood superiorly against the valve flaps. The valve flap edges will meet, closing the valve to prevent backflow. Blood flows through the heart in one direction, from the atrium to the ventricles, and out through the great arteries, leaving the superior aspect of the heart. The 4 valves that I just mentioned enforce this one-way traffic. They open and close in response to differences in blood pressure on the right side and the left side. Again, here are the chordae tendineae attached to the papillary muscle, which is attached to the wall of each ventricle, the right ventricle as well as the left ventricle. The heart is continuously filled with various amounts of blood. This blood provides little nourishment to the heart muscle itself. How then does the heart get nourishment? It does so through the coronary circulation, the functional blood supply of the heart, and the shortest circulation in the body. The left and right coronary arteries both arise from the base of the aorta and encircle the heart in the coronary sulcus. The left coronary artery runs toward the left side of the heart and then divides into 2 major branches. The anterior interventricular artery, also known as the left anterior descending artery, or LAD, or also known as the widowmaker, follows the anterior interventricular sulcus and supplies blood to the interventricular septum and anterior walls of both ventricles. The circumflex artery supplies the left atrium and the posterior walls of the left ventricle. The right coronary artery courses to the right side of the heart, where it also gives rise to two branches. The right marginal artery serves the myocardium of the lateral right side of the heart. The posterior interventricular artery, you can see that it's kind of blurred out or transparent. That is because it's letting you know that it is a posterior vessel. The posterior interventricular artery runs to the heart apex and supplies the posterior ventricular walls. The coronary arteries provide an intermittent pulsating blood flow to the myocardium, the muscle of the heart. These vessels and their main branches lie in the epicardium and send branches inward to nourish the myocardium with nutrients and oxygen. As might be expected, the left ventricle receives the most plentiful blood supply. It receives the most plentiful blood supply because it has a thicker muscle wall in comparison to the right ventricle wall. So if we look from the epicardium to the endocardium, you can see how thick it is on the left ventricle as opposed to the epicardium towards the endocardium on the right ventricle. The left ventricle has a thicker muscle wall because it pushes blood into the body. It is going to direct blood flow all throughout the body, so it works harder. The right ventricle is pumping blood right next door to the lungs. Let's continue on with the coronary circulation, the veins. After passing through the capillary beds of the myocardium, the venous blood is collected by your cardiac veins. These veins join to form an enlarged vessel called the coronary sinus. It empties blood into the right atrium. The sinus has three large tributaries: the great cardiac vein in the anterior interventricular sulcus, the middle cardiac vein in the posterior interventricular sulcus. Remember, that's why it's blurred out, it's transparent, it's letting us know that it's a posterior vessel. And also the small cardiac vein running along the heart's right inferior margin. This is the coronary circulation of the heart. This is the blood supply that supplies blood nourishment to the heart muscle itself. Unstimulated contractile cells of the heart, the neurons and the skeletal muscle cells, maintain a stable resting membrane potential. However, cardiac fibers are autoarrhythmic. They are called cardiac pacemaker cells. They have the special ability to depolarize spontaneously and so pace the heart. They are a part of the intrinsic conduction system of the heart, the electrical activity of the heart. These pacemaker potentials initiate the action potentials that spread throughout the heart to trigger its rhythmic contractions. This figure will represent the components of the pacemaker cells: the pacemaker potential, the depolarization, and the repolarization. The pacemaker potential is active when the potassium channels are closed and you have sodium channels opening. You have a sodium influx that alters the balance between potassium loss and sodium entry. The membrane interior becomes less and less negative, meaning more positive. The second phase is depolarization. This is where your calcium channels are open. Calcium is going to enter from the extracellular space. That leads into the third step of the action potential, repolarization. Repolarization, when your calcium channels have now closed and become inactive, you will now have opening of potassium channels and have a potassium efflux from the cell. Typical cardiac pacemaker cells are found in the sinoatrial and atrioventricular nodes. Impulses pass across the heart in order from 1 to 5, following the intrinsic conduction system pathway of the heart. It begins at the sinoatrial node, known as the SA node. The action potential will then pass to the atrioventricular node, known as the AV node, then on to the atrioventricular bundle of His. From there, the impulse will branch or split into the right and left bundle branches and end at the Purkinje fibers. This entire sequence of excitation or the action potential lasts 0.22 seconds. Let's begin with the sinoatrial node. This is your SA node. It is known as the natural pacemaker of the heart. It is located in the right atrium, inferior to the entrance of the superior vena cava. The SA node typically generates the impulses about 75 to 80 beats per minute. It sets the pace for the heart as a whole because no other region of the conduction system or the myocardium has a faster depolarization rate. And for this reason, it is the heart's natural pacemaker. And its characteristic rhythm is called the sinus rhythm that determines our heart rate. The impulse passes from the SA node to the AV node. The AV node is located in the inferior portion of the interatrial septum, immediately above the tricuspid valve. The impulse is delayed at the AV node about 0.1 seconds. This is to allow the atrium to respond and complete their contraction before the beginning of ventricular contraction. The impulse will then pass rapidly through the rest of the system, arriving at the atrioventricular bundle of His in the superior part of the interventricular septum. The AV bundle of His is the only electrical connection between the atrium and the ventricles. The short AV bundle splits into two pathways, the right and left bundle branches, which course along the interventricular septum towards the heart's apex. The pathway will be completed through the interventricular septum, penetrating into the heart apex, and then turning superiorly into the lateral ventricular walls via the Purkinje fibers. The Purkinje fibers are also called the subendocardial conducting network. The total time between initiation of an impulse by the SA node and depolarization of the last ventricular muscle by the Purkinje fibers is approximately 0.22 seconds in a healthy human heart. The SA node drives the heart at a rate of 75 to 80 beats per minute. Without an SA node, input from the AV node would depolarize about 40 to 60 beats per minute. Without input from the AV node, the atypical pacemakers of the AV bundle of His, the bundle branches, and the Purkinje fibers would depolarize only about 40 times per minute. This is incompatible with life unless you are in a hospital setting. It requires emergency interventions. This is the intrinsic cardiac conduction system of the heart. This is the electrical activity of the heart. Now let's study an electrocardiogram. Electrocardiography are the electrical currents generated in and transmitted through the heart. and spread throughout the body and can be detected with the device called an electrocardiograph. The electrocardiogram, or ECG, or EKG, is a graphic record of the heart's electrical activity. It is a composite of all action potentials generated by the nodal and contractile pacemaker cells at any given time. To record an ECG, recording electrodes are placed at various sites on the body's anterior surface. In a typical 12-lead ECG, 3 electrodes form bipolar leads that measure the voltage difference either between the arms or between an arm and a leg. And 9 will form unipolar leads. Together, the 12 leads provide a comprehensive picture of the heart's electrical activity. A typical ECG has 3 almost immediately distinguishable waves or deflections: the P wave, the QRS complex, and the T wave. The P wave represents atrial depolarization, where we have an action potential that spreads from the SA node to the AV node. The QRS complex that represents ventricular depolarization and atrial repolarization. It spreads from the AV bundle of His to the Purkinje fibers. And the last wave will be the T wave that represents ventricular repolarization, where the heart is at complete rest before the action potential begins again. We will also take note of the PR interval, the ST segment, and the QT interval. Here's a diagram showing a normal ECG. Here's your P wave, your QRS complex, and your T wave. The P wave represents atrial depolarization. Your QRS represents ventricular depolarization, and your T wave represents ventricular repolarization. Depolarization, the term means contraction. Repolarization is what the heart is doing at relaxation. Depolarization, contraction. Repolarization, relaxation. The P wave is small. It lasts about 0.08 seconds and results from movement of the depolarization wave from the SA node through the atrium to give atrial contraction. The large QRS complex results from ventricular depolarization and precedes ventricular contraction. An average duration of the QRS complex is 0.08 seconds. The T wave, caused by ventricular repolarization, typically lasts about 0.16 seconds. Repolarization is slower than depolarization, so that the T wave is more spread out and has a lower amplitude, meaning height, than the QRS complex. Because atrial repolarization takes place during the period of ventricular excitation, the wave representing atrial repolarization is normally hidden by the large QRS complex being recorded at the same time. What that means is that when the atrium are contracting, when the right and left atrium are contracting, the right and left ventricles are relaxing, and vice versa. When the right and left ventricles are contracting, the right and left atriums are relaxing. The upper chambers will always be doing the opposite of the lower chambers. Let's take a look at our PR interval. PR interval is the time from the beginning of the atrial excitation to the beginning of ventricular excitation. The ST segment is when the action potentials of the ventricular myocytes are in their plateau phases. The entire ventricular myocardium is depolarized. The QT interval represents the beginning of ventricular depolarization through ventricular repolarization, and it lasts about 0.38 seconds. This is a normal recording of your ECG. This is also a normal recording of your ECG. Here's your P wave, QRS complex, T wave. P wave, QRS complex, T wave. P wave, QRS complex, T wave, and on and on and on. This is a normal ECG rhythm. Abnormal rhythms will include this rhythm here. You can see that you have absent P waves. Your P waves are absent. So here your SA node is non-functional, and as a result, your AV node has to pace the heart between 60 and 40 beats. Here's another abnormal ECG reading. The AV node no longer works. Therefore, your AV bundle of His, the bundle branches and the Purkinje fibers will take over. And here is another abnormal ECG. You can see you have no clear P waves, no clear QRS complexes. This is actually a deadly rhythm. So emergency interventions will be taking place if we see this rhythm on an ECG. The heart undergoes some dramatic rhythmic movements as it alternatively contracts, forcing blood out of its chambers, and then relaxing, allowing its chambers to refill with blood. The term systole is the period of heart contraction. The term diastole refers to a period of relaxation. So if we're looking back on what we've learned so far, we can say that systole, contraction, will also be synonymous with depolarization. Diastole, relaxation, will also be repolarization. The cardiac cycle includes all events associated with the blood flow through the heart during one complete heartbeat, atrial systole and diastole, followed by ventricular systole and diastole. A step-by-step sequence of events through the cardiac cycle will help us understand the relationships between each of the parts of the cardiac cycle and the heart, pressure, and blood volume. The cardiac cycle is marked by a succession of pressure and blood volume changes that takes place within the heart. Because blood circulates continuously, we must choose an arbitrary starting point for one turn of the cardiac cycle. We begin with the heart in total relaxation. The atrial and ventricles are quiet, and it is mid to late diastole. So here's your sequence of events. We have atrial systole, early ventricular systole, late ventricular systole, early ventricular diastole, late ventricular diastole, and the cycle begins again. One complete cycle, steps 1 through 5, is one complete heartbeat. What's happening in each one of the events? The chambers are contracting or relaxing. The valves are open or closed, and the pressure is either high or low in comparison to where the blood wants to flow. Those are the three things that you're going to look for in each one of the stages. In atrial systole, the atrium are contracting. Atrial systole. Systole means contraction. So the atrium are contracting. If the atrium are contracting, that means that blood is flowing into the ventricles. If blood is flowing into the ventricles, they must be relaxed to fill with blood. So the atriums are contracting, the ventricles are relaxing, blood is flowing from the atrium to the ventricles. The pressure in the atrium must be higher than the pressure in the ventricles in order for blood to flow from the atrium to the ventricles. The atrioventricular valves, the tricuspid valve and the bicuspid valve, must be open in order for blood to flow from the atrium to the ventricles. If blood is flowing from the atrium into the ventricles, then that means that the semilunar valves must be closed. That is your pulmonary valve and your aortic valve. That leads us into our next stage, which is the early ventricular systole. The atrium are relaxing, therefore the ventricles are contracting. If the ventricles are contracting, that means that the AV valves are closed. The tricuspid and bicuspid valves are closed. It's early ventricular systole, so the pressure is not high enough in the ventricles to press open our semilunar valves yet, so they remain closed. Our aortic and pulmonary valves remain closed. The pressure begins to continue to rise as the ventricles contract more and more. The pressure in the ventricles is higher than the atrium, but not yet higher than the pulmonary trunk and the aorta. Once the pressure in the ventricles become higher than the pressure in the aorta and the pulmonary trunk, your your semilunar valves will open. The semilunar valves will open, allowing blood to flow from the ventricles into the pulmonary trunk to the lungs, into the ventricles, into the aorta, to the rest of the body. That then leads us to our early ventricular diastole. Ventricular diastole means that the ventricles are relaxing. If the ventricles are relaxing, that means that the atrium are also relaxing in early ventricular diastole, so the heart is at complete rest to allow for the action potential to begin. The atrium are relaxed, the ventricles are relaxed. The atrium are filling with blood, and the pressure is also starting to rise higher than the ventricles. All the valves are closed. Your AV valves are closed, which is your tricuspid and bicuspid, as well as your semilunar valves being closed, your pulmonary and your aortic. As the pressure rises higher in the atrium than it was in the ventricles, we lead into late ventricular diastole, where your AV valves will open and your semilunar valves will remain closed, and the cycle starts again. Because the mitral valve closes before the tricuspid valve and the aortic semilunar valve generally closes shut before the pulmonary valve, it is possible to distinguish the individual valve sounds by auscultating 4 specific regions of your thorax. Auscultating means listen, and we're going to listen with the stethoscope. So let's do some summary of general anatomy of our valves of the heart. Your atrioventricular valves will be your tricuspid valve and your mitral or bicuspid valve. The tricuspid valve sits on the right side of the heart between the right atrium and the right ventricle. Your mitral valve sits on the left side of the heart between the left atrium and the left ventricle. Your semilunar valves, which are your aortic valve and your pulmonary valve, are going to be situated between your ventricles and the large arterial vessels, pulmonary trunk and the aorta. The right semilunar valve is your pulmonary valve. Your left semilunar valve is your aortic valve. That's where they are anatomically situated in the heart. But that is not where the sound of the valve closing is heard. Your aortic valve is heard on the right side of the sternum in the second intercostal space between the first and second rib. Your pulmonary valve is heard on the left second intercostal space. Your tricuspid valve is found on, or heard, is heard on the right side of the sternum at the fifth intercostal space. and your mitral valve is heard on the left side of the sternum in the fifth intercostal space in the mid-clavicular line. How do I remember that? All physicians take money. All is your aortic valve, right second intercostal space. P is your physician's pulmonary valve, left second intercostal space. Tricuspid valve, fifth intercostal space on the right side. Take money. Mitral valve, fifth intercostal space on the left side of the sternum in the mid-clavicular line. All physicians take money. Knowing normal heart size and location is essential for recognizing an enlarged and often diseased heart. Please refer to your large and more detailed PowerPoint found in your weekly lessons to understand what cardiac output, stroke volume, and heart rate regulation is. Cardiac output is the amount of blood pumped out by each ventricle in 1 minute. It is the product of heart rate multiplied by stroke volume. Stroke volume is defined as the volume of blood pumped out by one ventricle with each beat. Cardiac output is the amount of blood ejected from the ventricles. Using normal resting values for heart rate, which is 75 beats per minute, and stroke volume, which is 70 milliliters per beat, the average adult cardiac output can be measured as 5 liters per minute. If you recall your chapter on blood, you learned that the normal adult blood volume is 5 liters. Cardiac output equals stroke volume times heart rate. They are directly proportional, meaning if stroke volume increases and heart rate increases, our cardiac output will be increased. They are directly proportional. So if stroke volume decreases and heart rate decreases, your cardiac output will also decrease. Please take a look at what regulates stroke volume and heart rate. If we take a look at this diagram, we're going to see the initial stimulus. What triggers a physiological response? The green is the physiological response, and the cardiac output being increased is the result. Exercise is going to influence our cardiac output. During exercise, we increase skeletal muscle activity, we increase our respiratory muscle activity, and we also activate our sympathetic nervous system, fight or flight. That in return is going to increase venous return blood flow to the right side of the heart, which is going to increase the force of contraction on the heart, which will also increase the amount of blood being ejected from the ventricles, which is our stroke volume. Everyone knows that during exercise, heart rate increases. Exercise, sympathetic nervous system activity or excitation, fight or flight, anxiety will all increase our heart rate. Also, hormones can increase our heart rate and stroke volume. Epinephrine, which is your neurotransmitter for your sympathetic nervous system, is going to increase our stroke volume. Thyroxine, which is our thyroid hormone, you've already learned in the endocrine system that it is going to increase metabolism, increase our basal metabolic rate, increase growth and development, therefore it will increase the output of the heart. And excess calcium, increased amount of calcium will also increase stroke volume and therefore increase the work of the heart and the cardiac output. Remember, calcium is what's going to allow the depolarization phase of the action potential to take place. Okay, so please know the initial stimulus, the physiological response that it will cause, and the result. A homeostatic imbalance can be if we have low calcium levels or high calcium levels, high potassium levels, or low potassium levels. Hypo means low, hyper means high. Hypocalcemia will be decreased levels of calcium and it depresses the heart. It will not allow depolarization to take place. Therefore, the heart is in a prolonged relaxation stage. Therefore, you do not have contraction and movement of blood. Hypercalcemia, meaning that our calcium levels are too high, it increases our heart rate and the force of contractility on the heart. Hyperkalemia and hypokalemia will have both the same detrimental effects. Hyperkalemia meaning too much potassium, meaning a prolonged repolarization, so it alters the electric activity of the heart, it alters the intrinsic conduction system of the heart, which can lead to heart block and cardiac arrest. Prolonged relaxation of the heart. Hypokalemia, when potassium levels are too low, also results in the same detrimental effects to the heart. Abnormal arrhythmias. Other factors that can influence our heart rate include age, gender, exercise, and body temperature. Age, a fetus, a baby that's growing in gestation will have a very fast heart rate. And the heart rate declines in the elderly. So as we get older, the heart rate slows down. Gender, females have a faster heart rate than males. During exercise, we know that that increases heart rate, but an exception to that will be trained professional endurance athletes. They can have a slow heart rate because of the professionalism and the high endurance that they place on their body, so that the heart rate will not always be at an increased level. Their body has been trained to beat at a slower heart rate to maintain the same amount of cardiac output that will meet the efficient needs of blood supply to their tissues. So Tony Romo, Dirk Nowitzki, Michael Phelps, all of them will have a slower heart rate than normal. Body temperature can also influence heart rate. Our heart rate increases with increased body temperature. Our heart rate decreases with decreased body temperature. Decreased body temperature is known as hypothermia. So as our body temperature decreases, the heart rate, the metabolism slows down. The heart's pumping action ordinarily maintains a balance between cardiac output and venous return. Where this is not so, a dangerous jamming up of blood or blood congestion would occur in the veins, returning blood to the heart. In congestive heart failure, the heart is such an ineffective pump that blood circulation is inadequate to meet tissues' needs. That is hypoperfusion. Hypo means decreased blood flow. Perfusion means the tissues. Blood flow to the tissues. Because the heart is a double pump, each side can initially fail independently of the other. If the left side fails, pulmonary congestion occurs. The right side continues to propel blood to the lungs, but the left side does not adequately eject the returning blood into the systemic circulation. The pressure in the blood vessels will increase and fluid leaks from the blood vessels into the lung tissues, causing pulmonary edema. Pulmonary means lungs, edema means swelling. If the congestion is untreated, the person will suffocate in their own fluid. If the right side of the heart fails, peripheral congestion occurs. Blood stagnates in body organs, and pooled fluids in the tissue spaces impair the ability of body cells to obtain adequate nutrients and oxygen and rid themselves of waste. The resulting edema is most noticeable in the extremities. the feet, the ankles, and the fingers. Failure of one side of the heart puts a great strain on the other side. Ultimately, the whole heart fails in congestive heart failure. This is irreparable. Treatment is directly primarily toward removing the excess leak fluid with diuretics. Diuretics are drugs that increase the kidney's excretion of sodium and water. Recall from AMP1 that water follows salt. Our diuretics are typically what we call Lasix or furosemide. Another treatment modality is reducing the afterload with drugs that drive down blood pressure and increasing contractility with digitalis, which is a heart drug. Heart transplants and other surgical or mechanical remedies to replace damaged heart muscle can provide additional hope for individuals suffering from congestive heart failure. Thank you.